Hello everyone, I'm going to talk to you today about ankle sprain. So what's an ankle sprain? They are ligament stretching or partial tears from forceful stress on the joint, and they are categorized as follows. Grade 1 are microscopic tears without ligament tearing or joint instability. Grade 2 are partial tearing of involved ligaments and laxity of the joint with moderate function loss. Grade 3 are ligament tearing with severe function loss and joint instability. The physical examination confirms a diagnosis made on the basis of patient history and differentiates an ankle sprain from a fracture. The examiner should look for areas of tenderness and swelling. Ecchymosis may be present and may be tender. The degree of swelling or ecchymosis may be proportional to the likelihood of fracture. Note, however, that blood usually settles along the medial or lateral aspects of the heels. Thus, the location of the ecchymosis may not correlate with the location of the injury. In addition, prompt treatment with ice, compression, and elevation of the ankle may reduce swelling and ecchymosis. Thus, these findings do not necessarily correlate with the severity of the injury. No bony point tenderness should be present. Point bony tenderness as well as bony deformity or crepitus suggest the possible presence of a fracture. Pain localized to the medial aspect of the ankle suggests a medial ankle sprain. Active range of motion must be assessed because Achilles tendon ruptures can mimic ankle sprains. In lateral sprains, passive inversion should reproduce the symptoms. Plantar flexion should also exacerbate the symptoms because this motion stretches the ATFL to its maximum. Epidemiology: ankle sprains are among the most common injuries seen in primary care. Lateral ankle sprains are most common, and most injuries are sustained during sport. The incidence of ankle sprain is higher among adult females than adult males, and they're higher among children and adolescents than adults. Female athletes have a 25% more occurrence than male athletes, with female basketball players at higher risk for first-time injury than those participating in different sports. It's estimated that more than 23,000 ankle sprains occur each day in the U.S. Half of all ankle sprains are sports-related. Highest incidence is in indoor or court sports such as basketball, volleyball, and tennis, followed by football and soccer. 25% of sports injuries in the U.S. and 75% of all ankle injuries are sprains. Etiology: lateral ankle sprains result from an inversion force with the ankle and plantar flexion. Medial ankle sprains are due to forced eversion while the foot is in dorsiflexion. Syndesmotic sprains result from eversion stress, extreme dorsiflexion, along with internal rotation of the tibia. So my interesting patient is a 31-year-old Asian male, presents for preventive care 1 day post-ED visit for left ankle sprain. Patient states 2 nights prior to clinic visit he was quote-unquote riding a penis-shaped mechanical bull. Yes, a penis-shaped mechanical bull. And his foot, quote-unquote, got caught when he was thrown off from the bull, and noted a laceration approximately 10 centimeters long. He denies hearing a pop. Patient reported being drunk at the time of the incident, does not recall any other falls or injuries that night. In the ED, he reported he was given 6 stitches and x-ray results unremarkable. Excuse me. He reports pain level 4 out of 10 at rest and 8 out of 10 if weight-bearing. He reports pain is non-radiating, improves upon resting, and unable to bear weight for longer than quote-unquote a few minutes. Patient can walk a few steps with a limp before needing to sit or stop to rest. He states that he's tried taking Tylenol or ibuprofen with little to no relief. Patient works in packing and reports being on his feet for long periods of time while lifting, walking, and standing, and requests for a doctor's note to be off work. He denies any prior injury to his left ankle. Constitutional: no weight loss, fevers, chills, or night sweats. No headaches, lightheadedness or dizziness. No shortness of breath, cough, or wheezing. Cardiovascular: he does report ankle swelling. No chest pain or palpitations. No abdominal pain or cramping or nausea or vomiting or constipation. No unusual rash or jaundice. No seizure disorder, focal numbness, or tingling. No unusual bleeding or bruising. Musculoskeletal right ankle pain, unable to bear weight. No other pertinent positives. No known drug allergies. No significant past medical history. Family history unknown. Social history, he denies tobacco use, reports drinking quote unquote only on weekends, about 4 to 5 drinks in one night. Patient admits to occasional cocaine use but states no other drugs use, and medications used none. Objective: BMI is 29.4, temp was 98, BP 130/67, pulse 87, respiratory rate 16. General appearance: patient is clean, well groomed, and dressed appropriately for the season or weather and appears to be a suited age. Skin: there was a 10 centimeter laceration with surrounding erythema, no cyanosis, no ecchymosis. Lungs were clear to auscultation and percussion, no wheezing, no rales. Non-pitting edema on dorsal lateral aspect of left ankle, no pedal edema, no patellar edema. Regular rate and rhythm, S1, S2, no murmurs, whoops, or gallops. Musculoskeletal, slower walking speed and shorter steps on gait analysis with crutches. Facial grimaces on weight bearing without crutches. Tender sulcus in the anterolateral aspect on inversion of the ankle. On palpation, no deformity, normal peripheral pulses, no Achilles tendon pain. He was alert and oriented ×3. Cranial nerves grossly intact, no numbness or tingling. Motor strength normal, reflexes normal and symmetrical. No signs of delusions or hallucinations, no evidence of anxiety or depression. Patient was pleasant and cooperative and no other pertinent positives. Some differential diagnoses: fracture, acute dislocation, infection, ligament strain, tendinitis or tenosynovitis, nonspecific foot or ankle pain, tendon rupture, tendinopathy, stress fracture, tendon subluxation. Often diagnosis can be clarified on the basis of a history of acute trauma and suggestive examination findings without the need of imaging studies. Although point-of-care ultrasound is a useful tool for assessing tendon injury and function, in cases of severe trauma or when the Ottawa ankle rules are not applicable, diagnostic imaging clarifies the diagnoses. The plan was for the patient to return to clinic in 1 week for removal of stitches or if symptoms worsen. Weight bearing as tolerated. If no improvement, an MRI would be obtained and referral to PT. Patient was instructed on exercises to prevent stiffness, restore function, improve range of motion, and restore normal flexibility and strength. Patient was educated on wrapping the ankle with a 3-way ankle joint mobilization to improve dynamic postural control, balance, and weight-bearing dorsiflexion range of motion. Patient was educated on the degree of injury and the need to take care of the extremity to prevent further damage. And he was also prescribed meloxicam 15 milligrams PO once daily, PRN for pain. Upon follow-up evaluation and treatment plan, he returned 1 week after for suture removal. The laceration was left open to air. The patient was advised to keep the wound clean and dry for 24 hours. Showering was okay after 48 hours, but not to soak, and to return to clinic if wound worsened or did not heal after 10 to 14 days. Also, at the follow-up visit, improved healing and decreased swelling on the ankle were observed. Weight bearing as tolerated also improved, as he was able to ambulate without crutches and was able to walk on his toes. And these are my references. Thank you.